Who's next? Ruud Selles, yeah.
Then we now...
Yeah, go ahead.
We now get Ruud Selles talking about patient perspectives on Dupuytren contracture treatments. No, sorry. Clinician-patient collaboration.
Okay, thank you, and thanks for sticking around till almost Saturday evening. So I will talk to you about patient-clinician collaboration, especially shared decision-making, and how measuring outcomes as part of routine care and data can, in our view, support that. So as a research professor without a conflict of interest, I'm probably even poorer than Jonathan Hobby, who just left. So we'll talk about assessment, and also today I saw a lot of people talking about getting fingers straight, which is of course one of the things that you're trying to achieve. So measuring journiometry is very relevant, and of course it's also really nice that people use patient-reported outcomes, and I think if you now look at trials in Dupuytren's disease, people either pick the one or the other as a primary outcome. And we use the Michigan hand in Dupuytren's patients routinely, and one of the nice things about the Michigan hand questionnaire is that it has all these different subdomains. So it's not just one score, but you can look at aesthetics separately from, for example, satisfaction with their hand function. So I will be talking about some of our experience and what we developed in something called the Hand Wrist Study Group, and this is really not Dupuytren specific. It's a setting of hand surgeons and hand therapists where they also treat Dupuytren's disease, and where we have been routinely measuring patients both with instruments like journiometry and strength, but also with patient, and maybe most importantly, with patient-reported outcomes since 2011. I won't go into a lot of details. We've written some papers about this. Since it's become a really large clinic with a lot of hand surgeons, we also have a lot of data by now. To be honest, I don't know how many Dupuytren's patients are in there, but it will be like in the tens of thousands by now that we have some data on. So why would you want to measure in your daily clinical care? And I think it's good to start realizing with the fact that there's a cost involved. So if you are setting up measurements and you want to really get some detailed information in your electronic healthcare record, or you're sending questionnaires to patients, there will be ICT and organizational costs involved. It will take time and effort from your patients and from yourself, and maybe in many situations that will take time away from treating or informing the patient. So, and then you have all these data, you need to do something with it. So there are some things you need to take into account, which actually means that the benefits of this need to outweigh the disadvantages. If you're interested in setting something up, if you would be bold enough, actually last year there was a really nice guide on how to implement patient-reported measures in your clinical practice. So I also will not be going into that. And if you want to do something like this and you're interested in what to measure, there's also a really nice consensus overview. So don't start reviewing all the literature again, I would say. There's, for example, from the ICHOM consortium, a specific group that looked at what to measure in hand and wrist disorders that includes Dupuytren's, and you can just adapt that. So, if you know what to measure, why would you actually measure? And I think, so for a long time, as long as I've been in this field, people say, okay, we need to measure because it helps me gain insight into my patient, it helps me inform my patients, and I think we need to be a little bit more precise on that. If you send a patient a Michigan hand questionnaire and they fill out all these items, what do you do with it when that patient comes into your office? So I think we need to be a little bit smarter about that. And the way that we tend to look at this is that there are multiple levels in which routinely measuring outcomes can be helpful. So if you have all these data, you can, on a scientific level or societal level, can do all kinds of outcome studies. And I think we've published about 15 or 20 Dupuytren studies with that, comparative effectiveness studies, creating prediction models. So that's something that you can do. You can do things like benchmarking and comparing your results to your colleagues and compare the outcomes. What I specifically want to talk with you about is this upper level where I think it helps, or it can help to, this patient-clinician collaboration on the individual patient level. And this is a little bit more than sending patients one PROM, maybe, but if you're having this infrastructure anyway, you can send them questionnaires, intake forms, and get a better picture of your patient before this patient is coming into your office, and use that data to start the right conversation. So if you are measuring, you know who's the patient in front of you, what's the current health status, is this patient smoking or not, you can have all this information, and you can also know what their baseline symptoms are. And if you have more data, you can tell the patient a little bit more extensively and data-based than data supported then on your clinical experience, what this patient can expect if he would pick one specific treatment. So that the idea is that that helps the shared decision making, and you can inform the patient what is the best treatment for them. So in the last maybe 15 years, we have been thinking of and trying to improve ways on how to do it, because it is not that simple. And I think and I will argue with some examples, that the instruments that we use are way too lengthy, that they're not individualized enough, and yeah, if you just send a questionnaire to a patient, it's not going to help you in your consultation, so you need to do something else, and I will try to make that argument. So the first thing is that so we use the Michigan Hand questionnaire, and as I mentioned, it has all these really nice domains, but it also has, I think, 37 or 39 items. And our patients get really annoyed that they have to fill in all of these items at baseline, and then maybe at 3 months and 6 months and a year, and they basically, many of them stop doing this. And one of the things that's really interesting that's going on is that we now have computer adaptive testing. So we don't need to ask all those questions, and we're actually in the process of developing a computer adaptive test where we can go from 37 to 4 items if you just want the total score, or 15 items if you want all the subdomains. But we also need instruments that are more patient-specific. So, for example, if you take this Michigan Hand questionnaire and you would apply it to a Dupuytren's patients, there are a lot of items in this questionnaire that are not relevant to a Dupuytren's patient. So they're not going to change on that either. We've been using something called the patient-specific functional scale, quite well known in the physical therapy world, and it asks this question: name maximally 3 the most important activities that you have difficulty with as a result of your disease. So, for example, in Dupuytren's. And what it turns out is that the things that our patient mention mostly in Dupuytren's disease are not mentioned, are not covered at all actually in the Michigan Hand questionnaire. And some might be covered in a DASH and some others somewhere else. So there's also a problem with them not being patient-specific enough. And this instrument is actually, if you want to do something, I think this is a really nice start, because it's ultra brief. It asks these patients what are the 3 most important things for you. You ask them to rate them on baseline, and then you ask them to rate them again maybe in 6 weeks or 3 months at your follow-up, and you can really see and discuss with the patients whether they have improved on that. So that's a nice, more patient-specific instrument, and one of the things that we've been busy with recently and that we just published last October in PRS is something which is probably an even briefer and more patient-specific instrument that aims to tailor and evaluate the treatment with something that we call the patient-specific needs evaluation. And what this is, it's an ultra-brief instrument. It takes the patient about 2 minutes to fill it in before they come into your office. I think it's most useful to do it when they come into your office. You can use it for free, by the way. It's very patient-specific, but also generic because you can apply it to all kinds of hand disorders and probably all kinds of treatments also outside of our field. And what it does is that we start with asking the question, what is your most important information need? So as a clinician, when you see this, you can start having a conversation on that. And then we ask them, what is your most important treatment goal? And the patient may also say, I don't have one. It's also useful to know. What is your current functioning on this goal? And what will you think you need to end up so that you will be happy with your treatment? And we think that's a useful addition because if that is something that as a clinician you feel you're not going to be able to obtain, then maybe you should stay away from treatment or you should start modifying the expectations of the treatment and tell them what is realistic. And then you can ask the same question again on this domain that I identified, how are they currently doing? So it's, I won't go into a lot of details, but it's basically like this NRS scale where a very brief question and a very brief score that patients need to fill in. Okay, so I think with shorter instruments and with more individualized instruments, we can help with that. And then this thing, so okay, if you do all of this, how do you manage expectations and come to shared decision making? And we started when we had our first group of patients making a booklet, which basically presented the average results of all previous Dupuytren's patients or some other disorder. And that is really nice, but it's also very generic. And I think today and yesterday we always talk about that it needs to be a bit more specific. And actually the next thing to do then is to start making prediction models. So prediction models combines previous patients but predicts an outcome not on the average of all previous patients, but on the individual characteristics. This is, for example, a model that you can use. The link is still active. I checked it today. And you can use that for your patients to see to what extent full extension will be obtained if you select either fascectomy or fasciotomy based on the baseline contracture rate. And for this instrument that I just showed you, we have also just created a prediction model where you can see whether this individualized goal of the patient will be met. So then the next step, if you do all of this in paper with the shorter instruments, it's probably doable, but it's a lot of information. And in a car, you also have a lot of sensors, a lot of information, and then we make dashboards, and dashboards presents the most important information and highlights things in red or starts flickering because if you want to look towards something. And most modern electronic healthcare records have a way to make your own dashboard now. So if you have all this data coming in, you can start picking out specific things. And these are a couple of combined screenshots from the dashboards that we have for our surgeon. The surgeon can show this to the patient and can start discussing things. And because of time, I won't go into a lot of detail, but there's these things that I just show, the elements of this patient-specific needs questionnaire, of the PSFS. It highlights, for example, if a patient reports a lot of anxiety and depression, because we know that it influences outcome, and it also integrates these prediction models. So if a patient comes in and you did your measurements, it automatically creates a prediction of outcome. And as I mentioned, you can start discussing this with patients. So where are we now? I think patient-reported data can make a consultation more efficient because you can start information up front to your patient and have it digitized, ready for you, and start having the right conversation. And it can facilitate shared decision-making. I think we really need to work towards ultra-short and personalized instruments. We shouldn't be having a PROM for all different hand disorders, but make something that works more generically. And electronic healthcare records can help you to synthesize all that data into a dashboard. And then the last slide, does this help? Well, just last month we published a study in Value and Health where we showed that using this infrastructure that I just showed you during a consultation, if you compare that to patients who were not shown these dashboards, The patient report better shared decision making, they report better patient experience and more positive expectations about the treatment. So I think this is nice evidence that, that this is something to do. And you can do all of it, but you can also really just take one or two of these instruments and start using it. So with that, I'll finish up and I thank you for your attention.
Thank you very much, Ruud. It's always jealous making when you show this. And there's actually a question I want to ask Anne. Anne, do you think that your patient group would be interested, and of course, Ruud, you can also answer it, to have access to something like the patient-specific needs evaluation? Do you think that would help, that would clear things up for them a little bit more and help them to get where they want to go? Or?
Yeah, of course we've got a problem with NHS finances in England, but I think they'd be happy to give it a go.
Yeah, you think, would it help a patient-centered group to?
Well, I mean, I didn't show that, but one of the examples that we sometimes show to be a little bit provocative in presentations, if you show a Dupuytren's hand, and then if you ask, so like a surgeon would just say, okay, I see a Dupuytren's hand, I'll make it straight. But that might not be what the patient is looking for. And I think, so, and maybe any good surgeon in a consultation will dig that out, hopefully, but I think structuring that a little bit and making sure with some of these tools that the surgeon becomes aware of this, and also maybe that the patient up front can think about it. They need to fill this in. They can maybe think about it for a day. So, so I think, well, I mean, we've made it. So it's they say ain't example, but I think it helps.
Bente.
Congratulations! I'm really impressed by the work you're doing and together with your team. I was wondering, what do you think about using the prompts as a telemonitoring tool? For example, instead of inviting patients each year for a checkup, which might not be possible some clinics. Because we did some research also that it can also prevent progression. How do you think about that?
Yeah, I like that idea, of course. One of the things in this clinic that we're doing is we're sending them like a pain questionnaire 1 or 2 days post-surgery with the idea if there's, and you can like something, you can send automatic triggers to a nurse to call a patient if there's something going on. You can prevent them from coming back in the weekend, but you can also do it in a different way. And actually one of the things that one of our projects that we are fantasizing about is that we cannot with the PROM currently measure contracture. But maybe we should come up with something that would work, and I'm not sure if it's doable. But yeah, then you can also do something like automatically take a picture, send it to the doctor, and then decide whether the patient needs to come in or not. So we can make things, I suppose, more efficient like that.
In the interest of time, thank you very much, Ruud. We have to move on.